Roughly 20 years ago, a small trial of 9 participants kickstarted a new chapter in OCD research, attempting to answer the question of whether psilocybin could interrupt the obsessive-compulsive cycle where so many treatments that exist now fall short. That 2006 study, led by today's guest, was one of the first modern investigations of its kind in the field. Now, 2 decades later, he's back with a randomized clinical trial that builds directly off of those early findings, testing repeated doses of psilocybin in a larger sample to help determine its therapeutic potential for OCD. Welcome back to the integration session where we explore the science, stories, and future of psychedelics. Today's guest is Dr. Francisco Moreno, who spent much of his career at the intersection of psychiatry and psychedelic science. In this episode, we're going to be tracing that landmark trial to his newly published 2026 study and asking what these 2 past decades of work can tell us about the mechanism, safety, and therapeutic potential of psilocybin for OCD. Let's get started. Dr. Moreno, welcome to the Integration Session podcast. Thank you so much for joining me today and taking the time to chat with me.
Thank you. Absolutely, Elena. It's my pleasure.
Yeah. So you've been kind of a pioneer in the psychedelic research space, I feel like, for decades. So you worked on maybe the first modern clinical trial that evaluated psilocybin for OCD, published in 2006, which is 2 decades ago, if you can believe it. So thinking back to that initial trial, what was your role in that and how did you come to be interested in psilocybin for OCD?
Yeah, that's a great question. I'd love to tell you more about how we got started with it. So I was a resident in the uh, mid 90s and had a patient that came in that had treatment refractory OCD, which means they had obsessive compulsive disorder and they were not responding adequately to the medicines that we were offering them at the time, which by then it included a lot of the medicines that we have now, the SSRIs and some of the medicines that we use for antipsychotics that were combinations and whatnot, and of course the cognitive behavioral therapy. Um, when we talked about things that make things better or worse, the person told us, there were some things that made things worse, and some things that made things better. They were using substances, illegal substances and alcohol. Um, and to abbreviate things, the things that really helped them do well were LSD or freeze-dried psilocybin mushrooms. When he took those, his obsessions and compulsions will go away, like completely go away. And they will remain well for days. And so this person kind of challenged themselves to use repeatedly, and they managed to bridge to be symptom free from use to use. And eventually they stopped using and they remained well in remission for a long period of time. And so that is what kind of woke me to the interest in psychedelics for treatment resistant conditions. My mentor at the time, Dr. Pedro Delgado, was a psychopharmacologist who was really great at looking at mechanisms of actions. And he and I were looking at, how can this be something that we may be able to use in practice? What can we learn from it that can help us come up with better treatment interventions? And one of the first steps that we started looking into is the possibility of replicating those findings that the patient had in a prospective pilot study for the treatment of OCD.
Mm-hmm. Interesting. And speaking more to that mechanistic rationale and maybe a little bit for listeners who may not be familiar with OCD and the mechanisms behind it, because this is our first episode focusing on that. Could you describe some of those key features and the unique mechanistic rationale of psilocybin for this disorder?
Yes, absolutely. So, of course, OCD is a condition that may be heterogeneous, may have a lot of different causes. and also the mechanisms associated with it have been proposed and involve a lot of different neurochemical functions, psychological issues, and whatnot. At the time, what we knew, this is in the late 90s, um, we knew that the serotonin reuptake inhibitors like Prozac, fluoxetine, sertraline, and others were helpful for OCD. Um, and other medicines that worked in other neurotransmitters, other antidepressants that work in like norepinephrine or whatnot, were not helpful. Uh, Antidepressants like the cipramine or bupropion never really helped OCD. Um, and then there were a few other things, right? So there's a medicine that is both serotonin and norepinephrine reuptake inhibitor. It's called clomipramine. It's commonly used for OCD. Uh, and the parent drug, before it breaks down to its metabolite, is really effective for OCD, but the metabolite is not as effective. And and the metabolite is not serotoninergic, but noradrenergic. And so we started seeing that these features were important. And then when you use some agents like ritanserin or ketanserin that are um, uh, perhaps uh, blockers of serotonin 2, some people had return of some of their obsessional symptoms. And of course, psilocybin and LSD work on serotonin 2, but as agonists as opposed to blockers. And at the time, we thought that that aspect of the pharmacological mechanism of the traditional indole-based psychedelic agents could really be what explain the clinical response. Now we know, of course, a lot more about OCD. We also know a lot more about the various complex effects and different pathways that are involved in the function of these agents, like the glutamatergic system and other aspects of interactions with different second messenger transmitters and things of that nature. So at the time, that was the foundation for a paper that my mentor led and I helped with as well, looking at the role of psychedelics in the treatment of OCD in the late 90s.
Mm-hmm. Interesting. So it seemed like at the time it was mainly a focus on neurotransmitter based drug action. And when did, if at all, there be more discussion about maybe the neural network changes? Because when I think about OCD, I think about very rigid and constrained patterns of thought, maybe higher cognitive rigidity. Is that also part of the rationale?
Yeah, so initially this was more of a pharmacological type of approach, and uh, some of the background that we were able to dig up as we were um, trying to explore what was written about from psychedelics and OCD, we came across a paper in which an individual who was receiving therapy for obsessive neurosis, titled that OCD had before being called OCD, really kind of helped them sort of evolve through that process. And so that's always been one of the aspects, how the individual experiences changes a person um, style of thinking and pattern of uh, circuitry dysfunction that may be explaining the symptoms. Of course, we've learned more over time through the pivotal work of other people who are doing imaging work, have contributed about some of uh, the uh, the connectivity of within and outside of certain networks that could explain some of that more flexible type of thoughts that can be associated with the response. But I'll tell you, independent of uh, what may be the sort of psychophysiological change that may be explaining symptoms, it was something that to us was very much pharmacological at the time.
Mm-hmm. Yeah, that makes sense. And going back to the 2006 trial, was it really difficult at that time, maybe more so than it was now, to get a study like that up and going? Especially because you mentioned that it was this sort of naturalistic, like individual case that sparked your
Mhm.
interest. So could you speak to that aspect and then also the study design and some of the key features of the particular protocol?
Sure. So it was very difficult. Of course, we started the conversation um, right before the year 2000 and started a discussion with the Human Subjects Protection Program at the University of Arizona. At that time, the leaders of the IRB were people from the Cancer Center. And in the cancer research practices of the era, people would often introduce a dose, and if that dose was tolerated, then it was sort of escalated until you saw either therapeutic benefits or tolerability or other adverse events that were really limiting the dose finding type of protocol. So in this case, um, we were looking at whatever literature had been published in terms of what are the doses in animals and in humans that may be triggering a full sort of psychedelic experience. And based on that, we came up with a dose per kilogram of body weight that could be a fully hallucinogenic, fully psychedelic dose, and then one dose that we thought was going to be uh, sub-hallucinogenic but have some effects on the individuals, and then something in the middle. We arrived at 300 microgram per kilogram of body weight as a dose that could be, it's like a medium to high dose that in a person like myself that's 100 kilos would be about 30 milligrams. And a person that weighs 70 kilos, that's like 21 milligrams or whatnot. So, um, and then the mid dose was 200 microgram per kilogram of body weight, and the small dose would be 100 microgram of body weight per kilogram of body weight. And so the IRB folks said, why don't you start with the 100 microgram? And if they tolerate it, then you can progress to 200, and then you can go to 300, which was a good idea. However, the FDA at the time said, hey, you really need to throw in a placebo for this pilot, right? Um, and they suggested that we do a very small dose. So we settled on a quarter of the lowest dose, which was 25 microgram per kilogram of body weight, which is basically what we now commonly known as a microdose, in some cases kind of in that range. Back then, we didn't talk a whole lot about microdosing and what effects it may have, so we just thought it behaved like a placebo. Um, Retrospect, of course, that was not a very good move. So that's how we kind of arrived at the dosing and the design. What we did is we inserted randomly after the first dose. So everybody got 100 microgram per kilogram of body weight on the first dose, and then randomly inserted the very small dose either at the second, third, or fourth session, and we separated them all by 1 week. Unfortunately, we didn't measure prospectively the effects of this. We just kind of wanted to demonstrate this was safe and there was a signal of benefit, which we found. Uh, Except since the very low dose also had some pretty good decreases in the severity of obsessive symptoms. It was thought to be a negative study since kind of all the doses sort of led to a decrease. Um, and so that's how we came about to the structure of the protocol, the methodology. And I didn't address the question about, was it difficult to kind of go to get to it? And And it was. At the time, we were getting some mentorship by other individuals that were doing research with psychedelic substances. Um, some folks that provided rating scales that were already being utilized in trials at the time, like Dr. Rick Strassman's hallucinogenic rating scale, before some of the more commonly used scales now became, you know, the go-to measurements of the and obtaining the substance was a major challenge at the time. We try to work with a couple of the institutes and centers at the National Institutes of Health, and we didn't have a lot of luck with it. The FDA and the DEA had a lot of reservations about the idea of utilizing a Schedule One substance in a clinical trial like that, and so eventually, with support of a large community of experts that involve people from MAPS, the Multidisciplinary Association for Psychedelic Studies in the day, and the Hefter Research Institute, and individuals that were selflessly trying to contribute to our training and guiding our ways of how do we best approach that, like um, uh, folks from California, UCLA, folks at in Boston and South Carolina, Stan Groff, Rick Doblin, um, uh, Michael Midhofer, um, and several folks that were very encouraging and helpful. Charlie Grove, um, and the team of Hefter, George Greer, and others were also incredibly supportive.
Sounds like you had a great team to support that work.
Yes, absolutely. We felt really privileged to have the tutelage and support, just encouragement and guidance
Hmm.
to really learn about what we needed to do. And
Hmm.
so it was a matter of continuing to work to try to obtain a good source. Eventually, we found a chemist that was able to manufacture 1 gram of psilocybin, and that's what we utilized uh, to do the protocol.
Hmm. And speaking more to the results, you mentioned a positive result. How did patients describe that experience? And can you speak more about the improvements that they observed?
Yeah. So again, we started with 100 microgram per kilogram of body weight, and everybody that came into that study were experienced users. So they had to be people who had been exposed to psychedelics, that have not used them in the last year, so they were not habitual users. They didn't meet criteria for substance use disorder, and there was a maximum of 20 uses in their lifetime they couldn't go over. But they all knew what they were getting into because they had experience in the past with psychedelics of this family of psychedelics, and so. Uh, the majority of the individuals had very pleasant experiences. Some people had very rich experiences in terms of the subjective uh, aspect of it. Um, and many of them had very dramatic improvements in the severity of symptoms. People that have not had a free day of OCD in decades all of a sudden had a really good outcome. And they, that sort of afterglow from the session remain. And at the time, we invited them to stay overnight in the hospital. And so we did ratings at baseline before they ingested the substance, 4 hours, 8 hours, and then 24 hours. And so the next morning, pretty much everybody was still doing really well. Some people without symptoms, and so some very dramatic. improvements. But those improvements were not very lasting. Um, there were a couple of people who reported lasting benefits after the last visit. Um, and there was an order effect. So when people came for the second visit, the baseline scores were like maybe almost 20% lower than the first time. But as people came for the week 3, 4, and yeah, 2, 3, 4, um, they 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 still had enough symptomatology to be considered in need for another session.
Mm-hmm.
So that also inspired us to think of multiple doses being required for people to improve in OCD. It might be that OCD is different to other conditions. We know that OCD had been historically more resistant to treatments. For many years, it was considered a very difficult to treat condition until the newer approaches to psychotherapy for OCD were introduced in the 70s, and the serotonin acting agents became to be the mainstay of treatment. Um, and still, we still have a lot of people that, in spite of all the advances that we have had, have a real tough time doing well on the current interventions that we have, and are not as likely to have a significant enough improvement to really change their life to their satisfaction.
Mm-hmm. And fast forwarding 20 years to 2026,
Hmm.
so you mentioned the repeated doses and your interest in that.
Hmm.
So, can you speak about the study design for your most recent study and how you kind of used what you learned from the 2006 study to inform that design?
Yeah, absolutely. So, what we wanted to do this time is to have a better control intervention. So, more of a placebo-like type of intervention, so that we could compare something that doesn't give you the benefit that a small dose could also give you. Our belief is that sometimes small doses could have acute benefit, but maybe also less lasting over time than other doses. And we don't know what the sweet spot is for the
Mm-hmm.
dose and the type of experience that people need to have. But that's part of what we're hoping, you know, our global team of experts are going to continue to explore over the next few years. Um, so we proposed to do a small pilot study again. This was self-funded. We worked with resources here in our department and the contributions of our selfless team members to this, and recruited 15 individuals, randomly assigned them to 3 groups, so that we had 3 small groups. uh, 5 individuals receive an active placebo. 5 individuals received the 100 microgram per kilogram dose, which was the initial first dose we gave before, and had pretty reasonable responses. And then 5 individuals had the higher dose that we had before. Um, and what we did is we gave people the same dose 4 different times, and we follow them for, again, every week. So for 1 month, they kept coming back, um, and uh, 4 of the individuals that got the active placebo, they received lorazepam, which is a sedating medicine that is used for anxiety. So in other words, it wasn't supposed to make OCD worse. If anything, it may help people be a little bit more chill, and maybe less upset by obsessions and compulsions if they take lorazepam.
Mm-hmm.
So it was not an inactive placebo, but it was something that, if anything else, didn't make the active medicine look better, but rather, if anything, it may have decreased the difference between the placebo benefit and the active substance. In summary, though, when you look at the end of 4 weeks, people that took the placebo didn't get better. Their baseline was in the high 20s for the white box, the scale that we use to measure severity, which is in the range of severe. It may have gone down maybe 3 or 4 points at the tops. Um, but then the other two groups, when you add the low dose and the high group, they were clearly different and significantly different once you pair the active together versus the other. Um, and Then what we did is instead of just following people prospectively, we actually switched everybody to receive 4 more weeks of the higher dose.
Mm,
They didn't know the protocol. Our team did know we were going to be doing that. And one of the concerns we had is a lot of the folks worked very hard to be able to be off their medicines or be available in Tucson or, wait for a long period of time to be part of the study and then you're on placebo, see you later. We thought it was a better thing to just have everybody on the 4 doses later.
mm-hmm,
And that was a very unique design so that some individuals actually ended up taking 8 high doses. The people that were randomly assigned to that, they took 8 high doses separated by a week. So that's the first study that I think really publishes such frequent and repeated use, demonstrating safety pretty much. So that was a nice contribution, I think, from that group. The other group that was low dose and then high dose maintained their response very well, continued with the improvement over time. And the people that took placebo and then moved to the high dose, they had a very dramatic change after switching, which sort of resembles some of those waiting list designs for some of the studies in which you have people without anything and then you give them the actual treatment and then you see the difference there.
mm-hmm,
So that was um, a design that allowed us to explore some answers, but also didn't allow us to explore others. Like, what's the durability of the benefit of having these 4 sessions initially? Um, and We also didn't know, or we still don't know, what the frequency of the sessions that's ideal to make sure that we really allow changes to take place and sit in for people.
mm-hmm,
Um, and Again, we have informed our protocol up until that date based on what we had learned from the individual that came to our clinic and
mm-hmm.
basically told us how things were. We've heard from a lot of other people that have explored this on their own in the past, and so we continue to learn more about other potential options for the timing and whatnot. But that was what was the design that we settled in at the time.
Mm-hmm. Yeah, so interesting. And especially because psychedelic treatment in clinical trials, often it's like 1 or 2 doses. So to have a group
Hmm.
that's getting 8 doses in a row is quite an interesting finding. And with that, obviously, there are some safety concerns associated with psilocybin. So, what would you say about maybe the emerging interest in like maintenance phase approaches to psychedelic treatments and repeated doses in order to keep those effects, those therapeutic effects, durable? Balancing that with maybe some potential safety concerns of delivering repeated doses.
Yeah, that's a really good question. Um, I'll comment first on the need for repeated doses or our approach with repeated doses. I remember when we first proposed that we were going to be doing this study, and we were talking with a group of experts. Stan Groff says to us, "Why would you pick OCD? Pick something easier. People with OCD may not, that rigidity, they may not be really ready to even have a full subjective experience." And he was, of course, very uh, focused in the dynamic process that would take place that will result in the changes later on, both symptomatically and behaviorally, and gave us examples of how difficult it was in some of the cases he had had and whatnot. And so we we knew from the get-go, similar to him, there were several other experts that thought that this may not be the best piece. to go with. So it might be that OCD may require multiple doses more so than other conditions. My personal appraisal is that if we are able to see good results with one or two doses in some of the clinical studies of depression, for example, that are leading to FDA approvals, um, we're going to see a lot more response in the future when this becomes approved and we have the possibility of dosing people more repeatedly and perhaps having an opportunity to do maintenance interventions. Um, the effect sizes that you see in the depression studies are really encouraging. We're very excited to see that. We're really excited to see that they will hopefully be soon approved by the regulatory agencies here in the States and abroad. And then that's going to be an option for people living with these conditions to use this option. But similar to many other things in the field of psychiatry, when they kind of come to the uh, sort of real practice, real life kind of intervention. Uh, if somebody does really well and then loses the benefit after a few months or starts kind of gradually kind of decreasing things, they're going to be curious and interested. And that's part of the treatment schema in psychiatry for generations. We've done that with psychotherapy, we've done that with medications. Of course, we do that with esketamine, ketamine, the repeated transcranial magnetic stimulation options. We do it with ECT, where we kind of go back and do a boost or whatever. We need a lot more longitudinal studies to tell us how long did the effect really last and what is the potential benefit of retreatment. We're learning a little bit from some of the protocols that are currently going on by some of the sponsored clinical trials that are going to be really, I think, illustrative in terms of what else we could be learning from that.
Mm-hmm.
So definitely a very good question that deserves a lot of attention. My bias is, of course, people may be in the future open to a lot more treatment interventions. And many times, one session is really transformative and lasting. We know that from the subjective experiences that people have, the mystical, spiritual changes that could come about, the very immediate benefit that some of our patients report. And we have multiple examples of how the symptoms go away after one session. But again, that's not the case for everybody.
Yeah, and we didn't talk a lot about the psychological support aspect, but what role do you see maybe psychotherapy playing alongside psilocybin for OCD?
Yeah, we didn't talk very much about it as we were talking about our clinical studies because our studies have used, again, a traditional psychodynamic informed approach to the preparation, the evaluation, the preparation, the the debriefing and the reintegration that happens for the individuals. But that's not psychotherapy, right? That is the real psychotherapy is a process that is developed between a provider and the individual and the system uh, that really kind of over time develops and goes through a variety of different phases. And what we do is three or four very profound, in-depth conversations with people while they're going through these experiences before, immediately through, and right after. That's not traditional, psychotherapy kind of approach. So it's the way in which people historically had facilitated the experiences for folks, and that's what a lot of the current clinical trials are also doing. Other than some of the ones that clearly incorporate psychotherapy like PTSD and some of the other ones that some LSD trials that are going on. So um, from my perspective, I think we still have a lot to learn in terms of how to best leverage these experiences for psychotherapy. Um, I really believe that psychotherapy is uh, a very important aspect of the treatments. And I think, we've learned a lot from psychotherapy with ketamine, for example. Although I believe the processes that take place with ketamine and with more traditional psychedelics is very different. Um, but clearly, based on what we know of psychophysiological mechanisms as well as dynamic uh, changes that the individual is going to be having, clearly psychotherapy is something that's going to have an important impact in a number of people. We're hoping in the future to be able to incorporate protocols that integrate different aspects of psychotherapy. There's already people around the world that are doing ACT or CBT with ERP or other kinds of interventions for OCD. And so in the next few years, we're going to learn a lot more to be able to give you a more informed response. But I'm just kind of shooting from the hip and based on what I believe could be going on.
Yeah, that makes total sense. And now that your 2026 trial is out and published, what are the next research steps? Are you going to be doing another study? Would love to know what you have planned.
Yes, absolutely. We are actually, we had just started with a new protocol in which we are going to be using whole mushroom psilocybin instead of synthetic psilocybin. So, utilizing three different groups, doses 10, 20, and 30 milligrams. This is not based on body weight, but just standard doses. We have partnered with our colleagues from the Scottsdale Research Institute who are uh, the manufacturer of this product, and we have started dosing individuals with this. So, um, similar to the previous protocol, we're looking at also some mechanistic potential changes, looking at functional changes in EEG and uh, magnetic resonance imaging, functional MRI, um, and trying to look at what else may be mediating some of the responses that individuals may be having. In this case, we'll be offering four doses, and then following people prospectively for 1 year. So that'll give us a longer duration of follow-up than the previous one, and give us an opportunity to test if the doses that individuals received are to predict the both the magnitude of improvement and the duration of the benefit, which we were not able to answer in the previous visit.
Mm-hmm. And do you have any hypotheses about what you'll see in terms of the neurobiological markers and also the durability?
Um, yeah, so the neurobiological markers, we now have data suggesting uh, this hasn't been published yet, but again, based on the preliminary analysis, changes in the default mode network, within the default mode network connectivity and increases with other regions outside of the default mode network that may be correlating with this. They kind of predict the magnitude of improvement, and they may also predict the durability of the benefit at 6 months. We're looking at uh, replicating some of those in a bigger number of individuals and looking at the dose effect. We're also looking at error-related negativity, which is an EEG electrophysiological marker of that kind of has been associated with the diagnosis of active OCD, and it improves after treatment with cognitive therapy or with pharmacological agents, and could be a bit of a biomarker also. So trying to see if we may be able to also learn at what point people are doing well enough so that we can say with the use of some of these biomarkers that we may stop the treatments or something along those lines. So that's part of what we're looking up in terms of what's next with our protocol.
That's exciting. I look forward to seeing the results in the future. Maybe I'll have to have you on again to discuss what you find.
Yes, absolutely. These are very kind of involved protocols, and being able to at one site enroll a very large number of individuals for us takes quite a bit of time. So it may not be in the next few weeks, but I would love to be back and chat with you a bit more about what we're finding.
Yeah, definitely. Well, those are all the questions I have for you, Dr. Moreno. Thank you so much for joining me and sharing your body of work. Congratulations on all of it. It's incredible.
Yes, thank you very much for an opportunity to share some of what we are doing. Similar to what I mentioned initially, that my mentor Pedro Delgado was really instrumental in the conceptualization and the practice of all of this. Our current team is also, uh, you know, to be credited with all the great effort that we're doing. My colleague John Allen, who's one of our distinguished professors of psychology, Katia Ehrman, Marisa Fernandez, and Brian Basie, Chris Wiegand, a number of others have been just um, unselfishly contributing to this kind of work, and really encouraging our team to continue to advance to the next questions. And I think they deserve the credit, and likely to be the people that carry the torch going forward with this kind of work. So
Mm-hmm.
thanks to them, and thank to you for letting us talk a little bit about this work.
Of course. Thanks so much, and we'll chat again soon in the future, I'm sure. Thank you for tuning into this conversation with Dr. Francisco Moreno. Thank you to the Center for Psychedelics Health and Research at Queen's University and our sponsors at the Ontario Brain Institute, the Canadian Biomarker Integration Network in Depression, and Providence Care Hospital. Until next time, be well and integrate wisely.